Healthy buddies, I'm Dr. Tirta Wijaya. Welcome to my channel where we will talk about various health matters. And today we will talk about shingles. Let's start with some myths. Have you ever heard people say that
Shingles only happens to old people?
this is a myth? It is true that the incidence of shingles increases substantially with age, but younger people can develop shingles too. Myth number two.
Shingles is just a skin disease.
It is not. It is much more than that. Shingles is a varicella zoster virus reactivation involving sensory nerve with a characteristic cutaneous manifestation. While others can only see their skin rash, some patients develop persistent neuropathic pain even after the skin looks completely normal. Myth number three.
Once you had shingles, you can never get it again.
It's false. Having shingles once does not provide absolute protection against it for the rest of your life. Myth number four.
You will die when the shingles rash makes full circle on your body.
Well, this one needs longer answer. Most of the time, shingles affect only one side of the body. It rarely forms a full circle. But when it does, it can be quite terrible that patients may feel that they are dying. I can't say that you will not die. You will surely die, full circle or not, just like everyone else. But mortality rate of shingles is extremely low. But it doesn't mean we can just ignore this condition. Okay, I've said too many parts already. Now let's talk more about shingles from the beginning so you can see where I am coming from. Shingles, or medically known as herpes zoster, is caused by the varicella zoster virus. This is the same virus that causes chickenpox, also medically known as varicella. Once this virus enters your body, it stays there forever. After someone recovers from chickenpox, the virus is not completely eliminated. Instead, it becomes latent, meaning it remains inactive inside sensory nerve structures called dorsal root ganglia and cranial nerve ganglia. For many years, even decades, the virus may remain completely silent. Then, if varicella zoster virus specific cellular immunity declines sufficiently, the virus can reactivate. It travels along a sensory nerve toward the skin and produces the characteristic painful rash that we recognize as shingles. So, chickenpox or varicella is the primary varicella zoster virus infection, and shingles or herpes zoster is reactivation of latent varicella zoster virus. Despite being caused by the same virus, many people think differently that chickenpox is a harmless childhood rash, while shingles is painful old people condition. Shingles is common, particularly as we get older. The risk increases substantially after 50 years of age, largely because varicella zoster virus specific cell-mediated immunity declines with age. In the United States, the CDC estimates about 1 million cases of herpes zoster occur every year. The lifetime risk is substantial too. About 1 in 3 people in the US developing shingles during their lifetime. But age is not the only factor. The risk is also increased when the immune system is impaired, like in hematologic or solid organ malignancies, HIV infections, organ transplantation, immunosuppressive medications, and certain autoimmune or chronic medical conditions. So, while shingles is particularly common in older adults, it is not exclusively a disease of old people. Then what about stress? You may hear people say, I got shingles because I was stressed. I would like to be able to use this simple and easy explanation, but I can't. There is some biological possibility and epidemiological evidence suggesting that significant physiological and psychological stress may contribute to reactivation in some people. But these studies showed correlation, not causation. So we can't really say that stress directly causes shingles. But I personally think that is one of several possible contributing factors causing inadequate VZV specific immune control, leading to latent VZV reactivation. So, what does shingles actually look and feel like? Many people think shingles is just a painful rash, but it's more than that. It can begin with pain, burning, tingling, itching, hypersensitivity, or numbness in a particular area of the skin. This is called a prodrome, and it can occur before the rash becomes visible. Sometimes the pain is so severe that the patient initially think that they have a cardiac problem, gastrointestinal problem, a dental problem, or another neurological condition depending on where the affected nerve is located. Then rash appears. Typically, there are group vesicles, the small fluid-filled blisters, classically described as dewdrops on the rose petals, distributed along one or more adjacent dermatomes, usually on the trunk or face. This is dermatome, an area of skin supplied predominantly by a particular sensory nerve root. The classic shingles appearance is a band or stripe of lesion on one or two dermatomes on one side of the body. Usually it does not cross the midline of the body, unlike chickenpox rash that spreads all over the face, trunk, and extremities in waves. The lesions usually progress from red or inflamed skin, vesicles, then pustule or cloudy vesicles, then crusting, then healing, generally in 2 to 4 weeks. The pain can be significant. Many patients feel it like burning, stabbing, electric shock, throbbing, or extremely sensitive to light touch. Even clothing touching the skin can sometimes be painful. Shingles can occur without a rash too. It is medically known as social sign hepatitis. This is an important but less common presentation. Here, the varicella zoster virus reactivation produces the neurological pain without an obvious cutaneous eruption, making it diagnostically challenging because the classic rash is absent. The diagnosis should be made carefully because many other neurological and visceral conditions can produce similar pain. Not all dermatomal pain is shingles, and different causes need different treatment. Shingles affecting the ophthalmic division of trigeminal nerve is called herpes zoster ophthalmicus or HZO. Ophthalmic means related or near the eye. Shingles with rash around the forehead, nose, eyelid, or eye, especially with eye pain, redness, photophobia, blurred vision, or other visceral symptoms, is an ocular emergency and must be treated immediately because varicella zoster virus can affect ocular structures including the cornea, uvea, and other parts of the eye and can potentially lead to visual impairment. There is also Ramsay-Hunt syndrome, in which varicella zoster virus affects the visual nerve and can produce ear pain, vesicles around the ear or ear canal, facial weakness, and sometimes hearing or vestibular symptoms. These are situations where let's see if it gets better is not a good strategy. In typical cases, the single diagnosis is clinical. Your doctor will look at the characteristic fascicular eruption, its dermatomal distribution, the associated neuropathic pain, and the patient's clinical history. That's it. When the presentation is classic, laboratory testing may not be necessary. But sometimes the case is not so straightforward. For example, if the patient is immunocompromised, the lesions are widespread, not confined to one or two dermatomes, or the rest resembles herpes simplex, contact dermatitis, impetigo, or other conditions. In those circumstances, PCR testing for varicella zoster virus DNA is the most useful laboratory test for confirming herpes zoster infection. The sample can be taken from a vesicle or lesion. Serology test is generally not so useful for confirming typical episode of shingles. Now we arrive at the most practical point of this video. What you can do and when. If you have any of single signs and symptoms you've learned just now, visit your doctor right away. Do not wait several days hoping the rest will simply disappear, because antiviral treatment works best when started early. The three commonly used oral antivirals are acyclovir, famciclovir, and valacyclovir. These drugs inhibit viral DNA replications to shorten the duration of the new lesion formation and viral shedding and reduce the severity of acute pain. But they cannot eradicate the virus from your body. Once it enters your body, it remains there forever. The antiviral medications treats the virus. It does not necessarily eliminate the pain immediately. Because shingles is painful, pain management is very important in the treatment. Examples of pain treatments for shingles are ice compressions, acetaminophen or paracetamol, non-steroidal anti-inflammatory drugs and SIDS, and when necessary, medications specifically used for neuropathic pain like gabapentin or pregabalin, and selected antidepressants such as tricyclic antidepressants for certain patients. More severe acute pain may occasionally require even stronger painkillers. The selection of pain treatment depends on severity and the patient's medical history. The treatment has to be individualized because these medications have their own contraindications, interactions, and adverse effects. Did you notice that I mentioned non-steroid anti-inflammatory drugs, but no steroids in the list? Well, even though some patients claim that they are the best painkiller as per their personal experience, systemic corticosteroids are not recommended for uncomplicated shingles. They may reduce pain in selected patients, but they do not replace antiviral therapy and have more adverse effects. Because corticosteroids mainly work by blocking immune cells activity, they can be problematic in immunocompromised patients or who have conditions where immunosuppression is undesirable. Remember that varicella zoster virus reactivations happen when the varicella zoster virus specific cellular immunity declines sufficiently. Steroids may suppress the immunity even lower. That is why they are not routinely used in shingles treatment. That being said, please do not self-medicate. All the health info I am sharing here cannot replace personalized medical recommendations from your doctor. You need to see your doctor to get the individualized treatments so your doctor can tailor your treatment plan to suit your unique condition. For example, if you have renal impairment, your doctor will adjust the dose accordingly. If you are immune compromised, treatment decisions can vary greatly from others with the same disease. Like most viral diseases, for immunocompetent people, shingles eventually resolve. The skin lesions typically heals within 2 to 4 weeks. But what your doctor concerns most is not the rest. It is the nerve damage. The most common complication is post-herpetic neuralgia or PHN. Post means after, neuro means nerve, and the suffix algia means pain. PHN means persistent neuropathic pain in the affected dermatome after the acute episode. The CDC defines PHN as pain persisting more than 90 days or 3 months after rash onset. About 10 to 18% of people with shingles develop PHN. It can last for months, even years. Other complications can include ophthalmic complications like keratitis, uveitis, even potential blindness. Then neurological complications, including meningitis, encephalitis, cranial neuropathies, and cerebrovascular complications. Number 4 is Ramsay-Hunt syndrome, involving the facial nerve and ear. And in severely immunocompromised patients, the virus can disseminate beyond the usual dermatomal distribution and cause potentially severe systemic disease. As I've mentioned several times in this video, once the varicella zoster virus enters your body, it remains there for the rest of your life. Up to now, there is no known treatment to cure it. The best we can do is to prevent it. The World Health Organization explains that the virus can be transmitted through contact with fluid from the shingles blisters, with transmission risk becoming very low once the lesions has crusted. Therefore, people with active shingles should keep the rest covered. Avoid touching or scratching it. Wash their hands frequently and avoid close contact with susceptible people. This is particularly important around pregnant women who are not immune to varicella, newborn babies, and people with weakened immune system. Once the virus enters our body, after we had chickenpox, the most important prevention strategy for shingles in eligible adults is vaccination. The current recombinant zoster vaccine is commonly known as Shingrix. It is a non-live recombinant vaccine. The exact age and eligibility recommendations may vary, but in general, 2 separated doses is recommended to immunocompetent adults aged 50 years and above. It is also recommended for adults 19 years and older who are or will be immunocompromised or immunosuppressed because of disease or therapy. Vaccination is still needed even if you've had chickenpox or shingles before, because previous episodes do not guarantee lifelong immunity against another episode. This vaccine is very effective. Clinical trial data showed that 2 doses of Shingrix provide more than 90% protection against shingles, post-herpetic neuralgia, and other complications. The vaccine can be used in many adults who are immunocompromised, where a live vaccine would not be appropriate. But you should always check with your personal doctor for this. That is my sharing today about shingles. Thanks for watching this video until this point. I hope you found this information helpful and can be a blessing. Kindly like and subscribe to my channel so you can continue to receive this kind of evidence-based health information from me. If you have any health questions or topics you want me to cover in our future videos, you can type in a comment below. But please do not consult your personal health issues here, as it can only be done personally with your doctor. This is my disclaimer. See you in the next video. Stay healthy and happy.